Kieran Anderson, group publisher here at Applied Radiology, and today we're here to talk about the risk, benefit in medical imaging, and I'm joined by Dr. Ehsan Samei, who is a distinguished professor of radiology and medical physics and serves as the chief imaging physicist at Duke University Health System. Dr. Samei, thank you so much for joining us.
Great to be here.
Also with us is Dr. Francesco Ria, who is a medical physicist and an assistant professor of radiology. Dr. Ria, thank you so much for joining us.
Pleasure to be here. Thank you.
You know, today we want to explore some of the new ways of thinking about risk and benefit in medical imaging. And really, instead of looking at radiation exposure alone, you guys have developed a new sort of novel framework that puts clinical benefit and radiation risk kind of at the same scale, allowing us to really evaluate total risk in a more informed and really more patient-centric way. And I brought you here today to talk more about this because I really feel like this matters. This matters both not only in the world of medical physicists, but we're here at RSNA. Radiologists who you work so closely with really truly benefit, sometimes without even realizing all the work you guys do behind the scenes. And you know, I'll start with you, Dr. Samei, about really setting the stage and why this work, why this matters. You know, your RSNA session frames this in really sort of an uncomfortable relationship between risk and benefit in medical imaging. So the question is, why has it been so difficult to, historically, to evaluate both sides of that equation? Why now, at this moment, to rethink how we assess risk in CT?
Yeah, thank you. That's a great question. So first of all, we want to do right by the patient. I mean, ultimately, we are here for the individual. And as long as I remember, in the field of radiology, we have been talking about risk and benefit and try to balance those. But when you really think deeply about this, you really cannot balance benefit and risk in a systematic way because they are two separate attributes that are measured differently. It's like balancing apples and oranges. So you can only balance things that are made of the same construct, state of the property. So even though we talk about balancing benefit and risk, we really have never had a proper formalism to do so. And we have not had a formalism to do so in the context of the word I use, is a patient-centric way. When we talk about risk and benefit, often we think about population. In fact, all of our figures of risk comes from a population risk. While when we are dealing with a patient, there is a real individual in front of us. So that balancing of benefit and risk, which we can talk more about, needs to be done in the context of the individual patient.
Really, really good point. Dr. Ria, I want to bring you in here now because your recent study really introduces a mathematical model that places radiation risk and clinical risk into sort of comparable units. And you've been talking about this here at RSNA and in publications. For those new to this idea, right? Not everybody really understands this. Can you walk us through how that model works and what problem it's designed to solve?
Yeah, thank you for the question. Yeah, we need to call it mathematical, even if nobody likes math, or maybe all likes math, because we need something standardized and uniform that we can use to compare. But literally what we try to do is try to put what Dr. Samei said in practice. So we have these two parts of the equation of the balance that in talk with each other. So we need to find a way to make them comparable. And why we were very used to speak about radiation risk as a number of adverse events or like side effects, all we had about the benefit, it was simply the radiologist thumbs up or thumbs down. We like this image, we don't like the image. This is suitable for diagnosis, it's not suitable for diagnosis. But behind this consideration, there is actually the diagnosis and what kind of improvement we are taking into patient life with this diagnosis. What is the outcome? So bringing this part of the equation in a numerical way allows us to compare the two and to try to find the balance, the optimal balance between the two. That is the ultimate goal of this model. It's not easy because we are talking about stochastic. Other medical fields, they have real numbers. We know how many people work into the surgery. We know how many people fix the problem. We know how many people we didn't fix the problem. Radiology, it is more of a stochastic, a statistical risk, so we need to deal with it, but it also It's a challenge that we are trying to address.
Something I found striking when we were looking at the data that were some of the key findings in your study was that the clinical risk outweighed the radiation risk by 400%.
On average, yes.
It blew me away across all demographics. So lowering dose too much may actually increase total risk. So what should a radiologist, a practicing radiologist, take away from this? What does this really mean, to them? And let's think about that from the perspective of not just maybe a radiologist at Duke in a major academic institution, right? That
Yeah.
has the resources, you two there, kind of there. There's also community hospitals that may not have the same access to this information. So what does that mean?
Yeah, first allow me to be a little bit, how can I say, direct. It is a bit sad and concerning that this data surprised us. Because we do radiology, because we know that it's worth doing radiology. We know that we are bringing benefit into patient life. So seeing the numbers should not surprise us. Otherwise, why are we doing this? Just to harm patients? I don't think that we are harming patients, actually. So this should not be surprising. The fact that people look at the number are surprised speaks a lot about how biased by radiation risk our culture is. So to try to answer to your question, I think that we need to evaluate our practice, considering what is the value that we are bringing to our patients, and considering also the task that we are trying to determine and to diagnose. And in this way, we can really do a patient-specific approach, because of course the task of diagnosis of tumor is not the same task as the diagnosis of fracture in my wrist. And doing a tumor for a pediatric is not as trying to diagnose a tumor for an older people, or for a woman, or for people of different races or ethnic groups. So we need to try to consider all these aspects the moment that we are trying to optimize our proceeding. We need to put all these factors into the equation.
One way to think about this is that, radiation is a resource that is at our disposal. We don't have to use it, but we are benefited by having access to this amazing resource. The question is that, how do we deal with it? We can look at it as a liability, or you can look at it as an opportunity. I feel like we tend to practice defensive radiology. I think is an alternative to defensive radiology is hopeful radiology. The radiation is here to benefit the patient. Ultimately, what we want to do, we want to benefit the patient. Yes, there could potentially be a side effect, could potentially, like double sort of qualification there, but we do know that the benefit is real. That's why we are using it. And therefore, our approach should not be one of fear, but one of respect. Same way you have a very sharp knife, you need to respect that instrument in the way you use it. Yes, you could do a lot of harm with that, but as long as you respect it, you can get a lot of benefit out of it as well.
Very, very good point. And as we sort of transition into kind of the clinical implications here and really rethinking CT optimization, Dr. Samei, to you, sort of given the findings that you have discovered in this study, how should this shift the way radiologists really start to think about dose optimization and image quality? And really, what does a more balanced, patient-centric, specific optimization approach look like in practice, in your opinion?
So we are still working this out, honestly. I don't have a formula to offer at the moment, but what I would like to submit to my radiology community is the fact that we do need to first put the patient at the center of what we do. So what would maximize the benefit to the patient? And the big part of it is that why the patient in our clinic in the first place. So let's maximize the benefit that they're coming for, right? In the same time, you need to minimize all the risk factors involved, medication risk, radiation risk, and you can put all of those in the same boat, right? You take a pharmaceutical agent, you also taking on some risk, right? So keep that into consideration, and then also ask yourself, or ask rather the patient the question, to see what is their preference, because their agency should also be central to the way we practice radiology. So we use the appropriateness criteria of the ACR, whether exam is justified or justified and so on. But if a patient is really want to make sure something is not growing or affecting, that needs to somehow find a way into the way that we optimize the protocol. So long and short of it is that let's figure out from a statistical population standpoint what would be the maximizing opportunity for the practice, and then accommodate the patient's voice in the process of practicing it.
Dr. Ria, would you add anything to that?
Yes, while Dr. Samei was talking, it came to my mind that a few years ago, separate from this issue, we performed a survey among patients to ask them what they know about radiation, about imaging. And there was a question that was provocative. We asked the patient, would you rather have the radiation dose reduced for your exam or the image quality enhanced? They were almost 50-50 split.
Interesting.
So I think that the patients, when he's coming to our radiology department, he wants an answer or she wants an answer. They are coming there because they have a problem and they want to figure out what's wrong with them. So they want the best that we can possibly offer. And of course they are concerned. I mean, but they are concerned about taking ibuprofen, like everybody's concerned. But the moment that we explain them that we are trying to give them answers that can potentially change their path of care, I think that we are already providing them a great service, and we are involving them in our process.
Interesting, very interesting. I'm loving this conversation. I think it matters to radiologists each and every day. Let's talk about the role of patient diversity in risk assessment, something you guys studied as well. I believe your study showed sort of a meaningful difference across both age, sex, race, both in radiation risk and clinical risk. How important is that optimization strategy, in your opinion, to account for these demographic factors, and how might this influence really protocol design? How would you help guide radiologists, your peers, your colleagues as they move forward with protocol design?
Yes, the sentence that we hear often is one size does not fit all. And this is true for science, of course, but we are all different. We know that patients of different ethnic groups are more exposed to certain kind of disease. So probably it's worth to try to have an exam at a little bit more detail, because the chance of finding something might be higher. And this is for ethnic groups. It's the same for pediatric, that can be more sensitive to radiation. So maybe we want to be a little bit more careful. Pregnant women, it's not just a matter of incorporating the patient size, but we need to incorporate all the patient attributes. And now we have the power to do so, because we have computing power, we have all the statistic method that we want. So we don't do this, it means that we are applying the same recipe to all the food that we're cooking, but that's I don't think that's an effective way to manage a restaurant. And let me clarify something. It's not just about increasing the dose. We found some cases where the dose was too high to get this optimal balance that I was talking about. It's a matter of finding the right dose for the patient that we are examining at that time, including all the factors that you mentioned that are, I mean, they are immense. So we
Right.
consider.
Right. No, absolutely fascinating, and so many things to take into consideration here. And as we start to wrap up and, think about what the future of this sort of risk to benefit modeling looks like, something that you two are both pretty passionate about. I'll start with you, Dr. Samei. As this model evolves, how do you envision, like, clinicians using risk, to benefit, risk to benefit assessment in everyday practice? What's needed next? Is it research? Is it more tools? Is it more education? What is it going to take for the field to adopt this more holistic approach to risk in CT? And how do we get that out to the masses? How does that, where does the rubber meet the road when you think about the practicing radiologist?
Right. So first, echoing what Francesco was saying, one size does not fit all. The good analogy of that needs to be, by the way, the approach that we will take. Now, three of us here do not wear the same size jacket. One size does not fit all. And beyond that, some of us might have tighter jacket than some other ones, right? So that personalization of the care needs to also be incorporated. That actually might be a good analogy in that space. So the way we approach the sort of different age cohorts or different sex cohorts should matter, right? I think we need to think about a culture shift of being perpetually apologetic about the use of radiation. Radiation is a gift, is a benefit that needs to be used properly, like everything else needs to be used properly. Yeah, I like to eat steak as well, but how much is it? So everything needs to be done in the context of appropriateness,
Makes sense.
but we don't have to apologize that we're having steak, right? So in other words, let's take advantage of what we got. As far as what is needed, I think we do need to characterize on the research side, do a more systematic characterization of benefit, just along the same line of what me and Dr. Ria have done. We have done it in the context of liver cancer, but can be done everywhere. So let's put that aside. So the science would be solid. And number two, that's the research side. Number two is that how we change the culture. How do we change the culture? How can we change the vernacular that we use? With me using the term radiation risk, I'm already telling you be scared of it because but if I use radiation safety, it's a much softer word, right? We are all about safety of everything that we do, right? So I think vernacular that we use, the culture that we use, that we apply in the practice of radiology, and the way we talk about it, not in a defensive way, but in a hopeful way, that's the way we should be striving.
Dr.
We
Ria,
are,
what
I
would you
think,
add?
sorry, no, just to, I think we are the only medical specialty that translates patient communication with risk communication. Yeah, patient communication is talking to the patient, talk about his story, talk about why they are in our department, try to understand what we can do good. It's not just communicating the risk. Of course, we want to communicate the risk, but we need to talk. I think that's a mental shift that we can try to do, and it can do exactly what it can help do it exactly what Dr. Samei says. So create a different culture over in our field.
Fascinating conversation. Last sort of question, because I'm just interested to know, you're here at RSNA, you're presenting some of the outcomes from your study. What's been the reaction? What are you hearing from, the because it's mostly radiologists here. What are they telling you?
They're happy because, when they can see on a piece of paper that what they're doing matters and it's actually beneficial for the patient, they stop being apologetic and say, actually, we are doing good. I think it's an optimistic message that we are broadcasting.
That's fantastic.
Yeah, I remember there was, even to this day, I think there are some regulations that measure the quality of a fluoroscopic exam in terms of how long it took. Well, if the patient needs longer exam and we are applying that, would that imply that we're doing a bad thing or doing a good thing? This is a situation that a bad metric can lead to unexpected outcome, right? So not only a bad metric in terms of not measuring the right thing, measuring the thing approximately, it's a bad metric because actually it's flipped, right? So we want to make practice of radiology consistent, but we need to have the right consistency. I remember early on, one of the physicists would say, we need to be consistent. Every CT exam that we do need to be at 120 kVt. That would be consistency. But if we can bring the consistency that every single patient needs to benefit from radiation, that is a better way of consistency.
Couldn't agree more. Couldn't agree more. Well, gentlemen, I want to say thank you very much for taking the time to sit down with me here at Applied Radiology. We're trying to break this risk benefit down, for the practicing radiologist, our primary audience, and to have two outstanding physicists sitting in my booth with me today I'm very grateful. Thank you, Dr.
Thank you so much.
Samei.
Thank you.
Dr. Ria, thank you very much. Appreciate your time.